Good day, ladies and gentlemen, and welcome to your Healthcare Workforce Increasing Diversity to Meet Your State's Needs webinar. All lines have been placed on a listen-only mode, and the floor will be open for your questions and comments following the presentation. If you would like to submit a question at any time during the webinar, you may use the chat box located on the lower right-hand side of your screen. Simply type your message into the box and click on the send button. If you should require assistance throughout the conference, please press *0 on your telephone keypad to reach a live operator. At this time, it is my pleasure to turn the floor over to your host, Melissa Hanson. Ma'am, the floor is yours.
Good afternoon, everyone. I'm Melissa Hanson, a program principal with the National Conference of States Legislatures Health Program. And on behalf of NCSL, I would like to welcome all of you to today's webinar, Healthcare Workforce Increasing Diversity to Meet Your State's Needs. Today's webinar is being recorded and will be available as an archive on NCSL's webpage. This audio archive and the slides will be accompanied by an NCSL publication on the issue of workforce diversity. A hard copy of this brief will be mailed to all legislators and legislative staff participating on this call. An electronic copy of the brief will be available with the webinar archive in 5 to 10 business days. Today's webinar is supported through the National Partnership for Action to End Health Disparities by the Office of Minority Health within the U.S. Department of Health and Human Services. Before we get started with today's panel, I would like to remind participants that NCSL is a bipartisan membership organization of state legislatures. NCSL advocates for the interest of states and provides policymakers the opportunity to exchange ideas. This webinar is a platform for information exchange, and we encourage a robust Q&A at the conclusion of the presentation. And remind listeners that opinions expressed on today's webinars do not represent NCSL or the U.S. Department of Health and Human Services policies positions. Now, I have the great privilege of introducing two fantastic panelists today. We are very fortunate to have with us Dr. Ned Colonge, President and CEO of the Colorado Trust. The Colorado Trust is a health foundation dedicated to achieving health equity. Prior to joining the Trust in 2010, Dr. Colonge served as the Chief Medical Officer of the Colorado Department of Public Health and Environment. He also served as the Chief of the Department of Preventive Medicine for the Colorado Permanente Medical Group and was a family physician for 10 years. His current academic appointments include serving as an Associate Professor of Family Medicine for the University of Colorado School of Medicine and an Associate Professor of Preventive Medicine and Biometrics for the Colorado School of Public Health. Nationally, he is the immediate past chair of the United States Preventive Services Task Force and a member of the Centers for Disease Control and Prevention's Task Force on Community Preventative Services and is a consultant for the Maternal and Child Health Bureau in the Health Resources and Services Administration. He earned his BA in chemistry from the Colorado College, a master's in public health from the University of Washington, and a medical degree from the University of Colorado. Following his presentation, we will hear from Dr. Richard Larson, a Vice Chancellor of Research at the University of New Mexico's Health Sciences Center. Dr. Larson is a board-certified physician. He maintains a peer-reviewed funded laboratory as well as his administrative duties. Richard was the recipient of the College of American Pathology Lansky Award for his leadership and contribution to the practice of pathology and the UNM Regents Lectureship for contribution to the university. Dr. Larson received both his MD and PhD from Harvard. He did his residency training at Washington University at St. Louis and his fellowship training at Vanderbilt University. His research interests include biochemical mechanisms of inflammation and new drug discovery. And in his spare time, he is the chairman of the board of directors for Tricor Reference Laboratories, as well as a member of the National Center for Genome Resources Board of Directors. Before I turn the floor over to our panelists, I would like to remind the audience that the webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking on the Q&A button at the bottom right corner of your screen and typing your question. We have left plenty of time for Q&A, so we encourage you to ask questions. We will also post the PowerPoint presentation on the NCSL website with an audio archive of the webinar. This archive will be ready in about 5 to 10 business days. Now I would like to turn over the floor to Dr. Colonge. Thank you.
Thanks, Melissa. I'm very pleased and honored to have been asked to attend and present during this webinar. I wanted to thank NCSL for taking on this very important topic. I also want to thank the University of Colorado San Francisco School of Medicine, who provided pictures that I think tell a visual story of the changing landscape of the medical workforce. Here's 1963's graduating medical school class, and if we jump forward all the way 40 years, we see what a difference time can make if we pay attention to the importance of workforce diversity. What I'd like to do with my time with you is follow this outline, make the case for health workforce diversity, and from there I'm actually depending on a report from the Institute of Medicine about the impact of workforce diversity in making sure we provide equitable care. I'd then like to show some information about the status of the U.S. healthcare workforce at this point in terms of diversity, or as close to this year as I can get. I'd like to talk about the legal framework for diversity efforts, as you are legislators thinking about that legal framework will be important as you consider potential approaches to addressing workforce in your own states. And then I'd like to go through a list of approaches to workforce diversity that have evidence of efficacy in the medical literature. I want to make sure that I give appropriate reference to the sources for the information, the Sullivan Commission on Diversity in the Healthcare Workforce, the Association of American Medical Colleges, who've actually been incredibly supportive and instrumental as a leader in looking for improved diversity in the medical school groups, and then the Philip R. Lee Institute for Health Policy Studies in the School of Medicine, the University of California, San Francisco, from where I was able to obtain more updated information. So I'll go ahead and get started with the issue of the case for workforce diversity. It really falls into 5 major areas of improving access, increasing patient satisfaction, the impact on quality of care, the importance of assuring culturally competent care, and impact on research. In terms of improved access, evidence is clear that minority physicians are more likely to treat minority patients and indigent patients and to practice in underserved communities. And in fact, nearly half of the patients seen by African American physicians and 1/3 of patients seen by Asian and Pacific Islander and Hispanic physicians are Medicaid or uninsured patients. From a study by the AAMC that was reported in 2014, you actually see that the data of entering medical school classmates who plan to practice in an underserved area. And you can see that the rates are much higher for groups such as our Black and African American patient students and our students who are Hispanic or Latino. I do want to pause at this point and just point out that it's going to sound as if this presentation is very physician-centric. And I want to apologize for that at the outset. One of the reasons is because most of the really robust data exists around physicians and medical students. I will show you some data for nursing students and then tell you that as we look across the entire hierarchy or the entire group of medical care providers, including oral health providers, dentists, that almost all of the data I'll show you, while most of it may be specific to physicians, can be found in all of the other professions as well. And the solutions apply across the different disciplines as well. So I just wanted to make sure I got that in early. So I talked about also increasing patient satisfaction, trust, and then what happens to that is something we call treatment adherence in medical practice. We know that when minority patients can select a healthcare professional, they're more likely to choose someone that has their same racial and ethnic background. And also, these relationships that are formed between patients and physicians of the same race or ethnic background really demonstrate higher levels of trust, respect, and those characteristics fit into treatment adherence. So what that means is that concordance in the healthcare provider relationship is more likely to be improved to improve kind of treatment adherence. I'm taking a pause because I'm getting messages on my computer I don't understand. So hopefully you're all still with me and I can advance to the next slide. So those were things kind of framed in the positive. There's some negative or less than high quality impacts of discordance in race and ethnicity in patients. We have found that the quality of interviewing patients of color is lower compared to with white patients. So providers actually don't do as good a job of asking questions. We know that Black and Hispanic patients report trouble communicating with their doctor up to twice as often compared with white patients, and that's regardless of linguistic concordance. Patients of color perceive better communications with race-concordant provider-patient relationships. And then there have been some studies reported that physicians actually offer different treatment options to patients of color, despite the fact that the prevention and treatment options wouldn't work differently for patients of color. And those differences are believed to arise from the unconscious biases that many of us have, that we make assumptions about what care a patient wants or recommendations that a patient may comply with. So these impacts tend to spin towards less quality of care. So why is it important to assure culturally competent care? We know that culture has a powerful influence on what we believe, how we behave, what kind of healthcare practices we have, and the language we use related to health. There's a strong relationship between cultural competence and quality of healthcare. We know that we need a culturally competent workforce with the knowledge, the skills, and attitudes and behaviors in order to provide the best care to our diverse populations. We know that providers who better relate to the culture and language and the social experiences of a given ethnic group are more likely to be effective in the care they provide to a community. When we turn to training, lack of diversity of medical students, and here I would say nursing students, physician assistants, pharmacists, and dentists, lack of diversity and ineffective cultural competency education creates training and treatment environments that continue to be biased, intolerant, and can contribute to health disparities. And then on the flip side, that we know exposure to diversity in medical school and in the other school settings improves cultural competence of all of tomorrow's doctors. A diverse student body brings a group, an array of different ideas to the learning environment. It helps students challenge long-held assumptions and broadens perspectives regarding race, ethnicity, and cultural differences. And the last area is, for an academician standpoint, we know that underrepresented minority physicians who are in the research world are more likely than their non-minority counterparts to do research that will actually help reduce racial disparities in healthcare. So that's the case I'd like to make for the importance of improving diversity in our healthcare workforce. I'd like to turn to some data on where we are today. So here is a slide that actually shows both where we've been and where we're going in terms of racial and ethnic diversity in the United States. And I recognize that we're between 2000 and 2025, but I like this slide because it actually put the projections out to both 2025 and 2050 that shows that we're actually becoming more diverse as a country as we're going forward in time. Where we are now is, and I just lost my connection, so what I'm going to do is go to the slide set. And I won't be able to do pointing anymore, but I'll be able to talk about the slides. So if you think about it, we're between 20,000 and 2025, and if you looked at the white and ethnic group, the white non-Hispanic group, we're actually right in between those two at about 67% of the U.S. population being non-Hispanic white. And when you look at the African American and Hispanic groups, we're at about 26% of the entire population. So we're right in between those two areas. However, when we look at the next slide, which I hope they can advance, the slide should say racial and ethnic minority physicians. They represent only 10% of the direct care workforce. So this is a map of physicians who are actually practicing today. And you notice that only 10% are in this underrepresented minority group that includes Black, Hispanic, and American Native, Native Hawaiian, and Alaskan Native groups. So this is a disproportionate representation of the medical workforce compared to the overall population. How do we get there? Well, the diversity of the workforce in all areas is a function of who applies, who gets in, and who graduates. So if we can advance to the next slide, we'll see kind of the course of medical school applications dating back to 1982 through 2011. I have tried to determine what caused the increased hump that actually maxed out in 1995 and then the subsequent decrease down to 2001. And it's difficult to get a feel for what happened, but I think most people feel the increase to 1996 levels had to do with expansion of the number of available slots, and that the downturn in 1996 had to do a lot with the cyclical nature of what professional students apply for, and a feeling that there was not a good work-life balance in medicine, so the students who were capable went to other areas. On the other hand, you also see this almost flat curve that's slowly increasing for Hispanic, Latinos, and Black and African American applicants. And so one of the things that drives the lack of diversity in the healthcare workforce is applications. There are similar slides available for nurses, and we see similar patterns over time. If we could advance to the next slide, the title should be Medical School Graduates by Race and Ethnicity. And this takes us up through 2004. So you see that we've gotten more diverse. A lot of our increased diversity in the medical workforce has been from increases in graduates from Asian Americans. And then again, you see a very flat increase, if any, in our Hispanic, Black, and Native American groups. And the next slide just takes that information a bit farther from 2002 to 2011, and again you see a very flat curve in terms of graduations. So that takes us from who's practicing to who is graduating from medical school. Then we have to look at the support structures that might help attract a more diverse student body. So the next slide talks about medical school faculty distributions. This slide is from 2011, and we see that the diversity is looking even a little bit more problematic in that the faculty that are Latino and Hispanic versus African American sum together to just under 7% total. So we don't have a representative faculty, and I think that has issues around the environment and the culture of the medical school in order to embrace diversity. Then what I would do now is look at, well, who in the faculty has positions that are upper-level positions, such as administration or department chairs. If we go on to the next slide, it's the distribution of deans and department chairs by race and ethnicity. The slide is from 2002. The upper graph looks at just all U.S. medical schools, where the deans and department chairs are predominantly white. If we then subtract out the schools that have traditionally had more African American students, Howard, Meharry, Morehouse, and the Puerto Rican schools, which are more Latino and Puerto Rican, we see that things look even less diverse in terms of department chairs and deans. So the lack of diversity is structural from the administration and leadership level to the students that matriculate, and we'll talk about the students that apply in just a minute. I promised you to show you some data from other professionals. This is from the Sullivan Commission, and so it dates back to 2000, where we see that there's a pretty significant difference in diversity between the registered nurse population, which is the pie chart on the left-hand side, to the U.S. population. Now, I was able to find some more updated information on registered nurses, and the news is good. So the African American percentage has increased almost by twice to 9.9%, and Hispanic has increased to 4.8%, which is more than doubled. So we're definitely going in the same direction, or in the right direction, and so I think that the nursing workforce to date has been more successful in diversifying than the physician workforce. I did, though, look at the leadership issues for nurses as well, and we see the similar pattern where full-time faculty is predominantly white, and the majority of deans of schools of nursing are also white. So we still have that kind of leadership gap in diversity that we think we need to make up. So I've tried to paint a picture of where we are today with diversity, and now I want to talk about kind of solutions. I wanted to start just by telling you that the Affordable Care Act, with all of its controversy for one reason or another, actually has quite a few provisions to support diversification of the healthcare workforce within it, including commissions and data sets that are especially designed to follow up and understand the areas of diversity for the healthcare workforce, then a series of training grants and programs that are really designed to help increase diversity in the workforce and increase service to underserved communities. There are population grants from CDC that really work at a higher level. And then there's continuing education support for health professionals across the spectrum of disciplines. So from a national level, there's actually a fair amount of support for diversification. As we get down to the state level, I felt it was important to actually think about the legal implications for decisions that legislators might make around diversifying the workforce. So the next slide is labeled the legal framework for consideration of race and ethnicity in medical school admissions. And what I've done is kind of gone through the different Supreme Court rulings and other rulings starting in 1978 through just this year to kind of paint a picture of the framework for how race and ethnicity might be considered in the admissions process. So the Bakke decision was in 1978, where the Supreme Court said that public universities have an interest in a diverse student body and could use race and ethnicity in admissions criteria. In 1996, the Fifth Circuit Court of Appeals reversed the Bakke decision for 3 states, Louisiana, Mississippi, and Texas. And then in 2003, the Supreme Court reinstated Bakke for those states in states that didn't have bans on affirmative action. So they actually reversed the 1996 ruling. In 2013, the Supreme Court said that affirmative action programs needed to pass a test of strict scrutiny to make sure that the institutions had examined other alternatives to diversifying student bodies other than thinking about race and ethnicity in admissions policies. And then in 2014, the Supreme Court said that states can indeed ban the use of affirmative action in college admissions. And that reversed a Sixth Circuit Court of Appeals ruling from previous. Then I thought I'd just show that there have been 5 actions in states, either ballot initiatives or executive orders that have banned the use of affirmative action in admissions decisions. And I recognize that this slide says anti-affirmative action. That is perhaps pitched in a direction. I wanted to be nonpartisan. These just are what they are. So where does this leave us when all these things come together? I would put it into 2 points, that higher education institutions may use race and ethnicity in their admissions decisions. However, race and ethnicity cannot be the only criteria for selection, and alternatives for diversification must be considered. On the other hand, states are free to make legal decisions via statute, ballot initiative, or executive order to preclude the use of race and ethnicity in admissions decisions. So this basically gives the decision-making to the states and upholds that ability to make those decisions. So that's the legal framework, and that's the current legal framework today. I'd like to then talk with the last bit of my talk around what state legislatures could think about in terms of supporting diversity. The first slide is a summary slide for the framework for increasing health care workforce diversity, where I put forward 6 different areas to consider policies. One of the most important is to increase the number of qualified applicants from underrepresented minorities. But then we need to look at barriers to applying, how to promote diversity and admission policies and processes in a state that allows that, how to support successful graduation for students of color and diversity in postgraduate training programs, how to support early practice and support leadership development. Just some more detail on that. Let's start with increased qualified applicants. So knowing the audience, I know the first 2 issues are things that legislators think about all the time, trying to improve the quality and the performance for education in K through 12 and improve graduation rates. The other point, the first point, though, is how do we create a culture that values education, that makes it something that all of our children aspire to? And from the standpoint of increasing the healthcare workforce, math and sciences really need to be at the heart of that culture. Not that the other disciplines aren't important, they're critical, but those 2 issues really support moving forward in a health care workforce approach. Then there are programs that inspire aspirations for medical careers. So we see programs where physicians go into middle schools and high schools and talk about, or nurses or physician's assistants, a myriad of disciplines across the healthcare workforce arena, and really talk to students about the promise and the ability and the excitement about their own career selections. This is incredibly powerful if the students recognize the healthcare professional as someone that looks like them. The next approach is to really intentionally develop interested and promising candidates. And so we see mentoring programs for youth across the education spectrum, and then pipeline programs, which I think you'll hear a little bit more about, that can target both middle school and high school. But then there have been interesting baccalaureate programs where medical schools have worked with colleges to say if students from diverse backgrounds meet certain criteria, they're guaranteed admissions to medical school. So that's the developing interesting, promising candidates. And then finally, preparatory programs, and here it's more pre-matriculation. How can we take students in baccalaureate programs and better prepare them for potential careers in the healthcare workforce? When we look at barriers to applying to healthcare programs, there are programs that do outreach to and recruitment of applicants. So once we develop this pool, how can we do outreach and get applicants to think about our program? There are preparation support programs. So the AAMC runs programs that actually help students of color prepare their application to get into medical school. there are also preparatory programs for the standardized tests. So I picked here on the medical college admission test, the MCAT, but I'll point out that most nursing programs, all physician assistance programs, pharmacy programs, and other health-related programs require taking the GRE test as part of the assessment and the application process, so helping students prepare for that. These applications are not inexpensive, and so programs that provide financial assistance for the process itself can encourage students to apply. And then once admitted, scholarship programs that defray the cost and decrease the financial burden on students, and then low-interest loans really become helpful in making a decision to pursue a healthcare workforce career. We do know, for example, that African American physicians leaving medical school have a significantly higher debt load than their white counterparts. The next slide talks about promoting diversity in the admissions policy and process, and three points I'd like to make. Standardized tests, MCATs and the GREs, have been well studied, and there is a cultural bias that affects performance and ability on these standardized tests based on racial and ethnic backgrounds. And so there have been a lot of work in thinking about the appropriate place for standardized tests in selecting candidates. I'll also tell you that the MCAT, which is required for medical school entry, has almost no relevance in terms of predicting the clinical ability of a graduate after medical school and training. You could have diversity criteria for applicant assessment selection, so I think we've talked about that enough, but also think about diverse admission committee members. The next slide talks about supporting students while they're in school and then immediately after school. The first one is, how do we create an institutional culture and environment that supports diversity? Actually embracing the diverse student workforce across the disciplines can be very important. We found that cultural competency curricula help support actually the students of color, because there's now better understanding and intentionality around training around cultural competency and embracing the diversity in the workforce and the student body. Schools have put together early matriculation preparatory programs where students of color actually start during the summer to give them a head start on the academic activities that they'll have in medical school or nursing school going forward. You can create mentorship programs with existing faculty and practicing physicians, and then we found a lot of success if you dedicate administrative and educational support services for students of color. The last two bullets talk about postgraduate training, so that's when you train to be a family doc or a pathologist or a surgeon or one of those subspecialties. And this is an area where I don't have a lot of strong evidence, and yet it's critical if you want to diversify your workforce in a given state, that the people that train there are diverse, because you tend to go into practice and to provide services in the community where you do residency training. And I wish I had a robust group of recommendations, but I don't in that area. Supporting early practice. So Colorado actually has a kind of a state health service corps program where we put all our loan repayment and early practice support programs in a single program to diversify the medical workforce and to assure that people are placed in areas of need such as rural areas. Loan repayment and forgiveness programs are incredibly useful in supporting physicians who get started, and we're just now starting to look at these practice startup grants and loans that allow someone to settle in an area of need but not have to face the onerous costs of getting the practice up and running. The last area was leadership development, and health-related leadership programs for people of color are really important. Investigator diversity policies for research grants is something that National Institutes of Health already does, but you can do it on an institutional basis as well. recruitment and retention programs for faculty from underrepresented minorities. We have to have a faculty that reflects the student body to maximize our effectiveness and efficiency. And then finally, let's help our faculty of color get promoted and get into positions of authority within medical school and nursing school administration by support programs. So my last slide is just a summary slide about strategies for workforce diversity that I'll leave you with. It's the one slide you can look. The thing that's on here that we didn't talk about was data-driven planning and policy, and I'm making that pitch from the standpoint of learning the diversity of your own state. You're going to see a great example of that in the next presentation, but thinking about where you are and where you want to be needs to be data-driven, and that's my plea to you to understand the diversity in your own settings and be intentional about policies that can improve it. And with that, I will end and turn things over to Dr. Larson for a very specific presentation around his state.
Thank you very much, Dr. Colonge. I'm very pleased to be here, and I very much appreciate the opportunity that NCSL has tell you a little bit about what we're doing in New Mexico. As a way of background, New Mexico is a majority minority state. We're 45% Hispanic, 40% non-Hispanic white, 10% Native American, and then about 3% African American. One of the things that we really see as our goal as a medical school and as a health science center is not only to address the diversity issue of the workforce in New Mexico and for the entire state, but to address the severe shortages of healthcare workforce that we face in this state. One of the great breakthroughs that we were able to make is that working with the legislature, we were able to pass House Bill 19 in 2012, which really allowed us to engage in a lot of what Dr. Colonge just alluded to, evidence-based direction of our workforce efforts. And I'd like to review that briefly and then also touch on a lot of the tactics we've used that were reviewed in the previous talk and our experience with them in educating a diverse workforce. So in 2012, one of the things that we worked with our state legislatures was to pass this act. It did three key things. One was that it required all our licensing boards to develop a survey on practice characteristics. Two of the key things that came out of this, we were able to now know all the physicians or other healthcare workers that are licensed in New Mexico, not only that they practiced in New Mexico, but where they practiced and what they practiced, how they practiced, and many of their demographic characteristics of themselves as well as their population that they serve. All of this data was directed to our Health Science Center for Stewardship, and a statewide committee with broad constituency was formed, which I chair, and we are required each year to give a report to the legislature and the governor, which in many ways has been very successful at building our workforce effort. This just gives you a couple of the flavor of where we are as a state. We do have 8,400 licensed physicians, for instance, but only 56% of them practice in New Mexico. This, of course, was very surprising to us. Because of the nature of the military, the public health service, and other federal opportunities, a lot of individuals license in our state but don't actually practice here. Also, it used to be that you would send your licensing to your home address, and in New Mexico, 40% of the population receives their mail at the post office. So when we did this under previous licensure data, it showed that 40% of our physicians practiced at the post office. Since they don't actually live in the same area that they practice in, we were never able to get good data on where people practiced and what they did. Our shortages in nurse practitioners and other areas that we've looked at all are similar in terms of discovering how many actually practice and where they practice in New Mexico. This has been able to allow us to show distribution maps like the one that you see before you. Based on every county in New Mexico, we're able to compare to national metrics and see where that county is with its shortage or not of different health care providers. I'm showing you one here for primary care providers. We've obviously done this for other other physicians such as surgeons, obstetrics, gynecologists, psychiatrists, and so forth. We generally have shortages across the board. Bernalillo County in the center, which is green, is pretty much green all the time. That's where we're located as the academic health center. But the other areas of the country, of the state, are quite short. Just as a reminder of size, if you placed our state over the East Coast, our northern border would start about halfway up New Hampshire and Vermont, and our southern border would be south of Washington, D.C. We would extend through most of Pennsylvania, and half the state would still be over the Atlantic Ocean. So we face significant geographical considerations in delivering rural care. 1 million people live in Bernalillo County, and the other million in New Mexico are distributed throughout all the other 32 counties. About 30% of our current workforce comes from an underrepresented minority. When we do this sort of analysis, just so you can see the sort of things we get, we have about 153 primary care physicians that are needed. We include osteopathic doctors in that calculation, about 336 nurse practitioners or physician assistants. We have shortages that are less severe in a number of other professions. And one of the things that we unfortunately lead the nation in is our average age is the highest physicians in the country. And that's really because what we've seen as we've analyzed this data in a granular way, particularly in rural counties, physicians are reluctant to retire if there are only one or two providers in that county, and if they retire, they know the county will not have any health care support, so they tend to stay working until they can recruit who they pass their practice off to, and that is not always an easy task. So the strategies we've taken to address this are several-fold. We certainly have engaged in loan for service, loan repayment, and scholarship programs as aggressively as we can. Those are really short-term solutions in our view because they only put us in competition with neighboring states. They don't increase the supply and direct the supply to the areas of New Mexico that we actually need to direct at. Our BAMD program, which is shown farther down, is specifically designed, and I'll show you in a subsequent slide, to target students into the rural areas, as well as our residency program and other programs. And I can speak to these in a greater detail, but I will only be able, due to time constraints, briefly touch on them. One of the things we do with our BAMD program is this really identifies promising students who from a rural background who are interested in primary care. We know from the analysis of our data that there is a very high likelihood that students from rural New Mexico will go back and practice in New Mexico. Over 90% of our nurse practitioners practice in the area that they were raised in, and so this becomes a very important consideration for us in trying to decide who gets into our professional schools and where they would end up practicing. We know that this is also a strong driver for our medical students and residents as well. One of the challenges, you know, with this is when you're going to identify students from a rural background, many of these backgrounds are educationally disadvantaged, and it's a real challenge to identify a promising student who can be expected to be successful at getting through the BA and the MD program. What we've learned over time, and I think we've learned this the hard way over the last 11 or 12 years, is what are the things we're really looking for in a student from a rural background that would predict they'll be successful in academics if they haven't had an academically sound preparation. And I think in addition at taking a holistic approach, some of which I'll show you in subsequent slides, which will helps with address the diversity issue, what we've really come to believe is that if we can identify students who have strong leadership characteristics in their background, strong background of excellence in something, not necessarily academics, or some sort of indication that they're strongly motivated, this not only predicts their ability to do well in their first year of math in college, but their ability to do well throughout the whole program and not become an at-risk student. And so this has been quite a learning process for us and has helped quite significantly. The other thing of interest is we've analyzed all this data that was a little bit of a surprise to us is that our strongest predictor of retention in New Mexico in an area we need is whether or not they did a residency program with us. It's not whether they went to high school here, not whether or not they did a college here or medical school. It's the residency program. If they were a residency program and medical school, it was even higher. We have a 70 or 80% retention rate of those individuals, and again, if they have college, it's even more. The key to placing residents is we set up a whole variety of programs to expose them to practice in rural areas. Generally, if a resident hasn't been trained in a rural area, they won't practice in a rural area. They'll practice where they've been exposed to, and adding this sort of experience has really increased our placement of residency physicians in New Mexico. This is just to show you of all the practicing physicians in New Mexico, a little bit more than 1 in 3 of all physicians in New Mexico have been trained in some capacity through one of our programs at UNM, which are typically directed toward both the diversity and the maldistribution and shortage issues that we have. The overall, again, just to remind you, about 30% of our overall physician workforce in New Mexico are underrepresented groups. And that continues to increase as we continue to have, make a whole variety of our efforts more robust. One of the things that was mentioned in the previous talk, and I'll bring up here, we do have a holistic review of our medical students as they're coming in as undergraduates or for those students entering our BA/MD program. We obviously consider a whole variety of issues, as well as the ones I've mentioned about excellence, leadership, and motivation that really, I think, help us identify the pool of applicants that are least likely to become at risk and most likely to be successful, as well as come from racially and ethnically diverse backgrounds, and in our case, being from a rural or medically underserved area as well. One of the other things that was alluded to was our pipeline programs, and at least this slide on my slide is not showing all the detail. Each column actually represents a pipeline program we have. There was some detail on each one of those pipeline programs. I can briefly summarize it. We have pipeline programs that called our Dream Makers Health careers that reach back as far as junior high. Our general feeling has been, and our experience has been, it's very hard to encourage students, particularly from rural areas or underrepresented groups, to think about a career in health professions if they've never known anybody or never seen anybody from a healthcare profession. And so we have several programs targeting nursing, pharmacy, allied health, and physician groups to enhance the interest that comes from those rural areas and underserved areas. And so we try to target the pipeline programs and every level, from that level all the way up, in terms of targeting the workforce that we produce for rural New Mexico and for it to look like the population of New Mexico. Because we also have found and have many examples where a more diverse workforce leads to more appropriate health care for the population they serve and actually better access of health care as well. And with that, I know that was a very fast overrun of what we do in New Mexico. I'm glad to stand for any questions, and thank you again for this opportunity.
Great, thank you. I'd like to take the moment to thank all of our presenters today for those wonderful presentations, very informative, and open up the floor to participant question and answer. As a quick reminder, to ask a question, please click on the Q&A button and type in your question. Please make sure that your questions are listed to all panelists, and remember that the questions will remain anonymous. Due to limited time, if we are unable to get to all of the questions submitted today during the live event, an NCSL staff person will be in contact with you next week to ensure that your question does get answered. The first question I have goes towards Dr. Larson. How does New Mexico utilize foreign-trained graduates or foreign-trained medical providers?
Let me answer that in two different ways. If they're seeking to become a physician, we treat them just like anybody else has to be treated. But we do recognize that in New Mexico we have a significant number of foreign-trained healthcare providers, and this is not only in our Hispanic population, but in our Native American and other populations as well. And they may not qualify to practice as physicians, for example, in New Mexico. What we do is offer those individuals and try to direct those individuals to other areas of practice. One of the most areas that we're very far ahead on, and I think is very worthwhile, is our Community Health Workers Program. This is a program where, individuals, I think many of you are familiar, individuals and communities serve as a capacity to help the communities best and the individuals in it best navigate through the healthcare system and network out to other larger communities as well. Those groups and that way we deploy it's a little bit different than others, but clearly finding that sort of role for them as others is what we try to do the most of at this point. And that gets them engaged into the healthcare workforce more rapidly and around all the regulatory barriers.
Great, thank you. The next question is for Dr. Colange. Quickly, you mentioned that the data about faculty diversity was from 2002. Do you have a sense, is there more recent data? Is anyone looking at this issue?
The AAMC does look at faculty diversity on an ongoing basis. Those were the latest published results. So the surveys always lag real time, and I try to get the most recent data available. There is a feeling that there have been some improvements in 2014 in terms of faculty, overall percentage of faculty. The issues about higher up levels have not budged very much, and as you might expect, those are going to lag behind the rest of the faculty development issues. So I would say that the direction is going in the right way. It still lags behind even the diversity of the matriculant pool, and that additional attention needs to be paid. There's one other thought I had, but there was also some encouraging 2014 results that the number of Latino applicants or Latino college graduates taking the MCATs actually increased this year, as did the number of women. So we are seeing some indications that activities by states and emphasis by both colleges, medical schools, and a lot of the things we've been talking about do work and have some traction, even to the level that they're showing up in the overall average numbers across the country.
Great, thank you. The next question is actually sort of directed to both of you. There's a lot of interest in medical school education and particularly residency slots and how a state gets residency slots. Dr. Larson, do you want to start?
Oh, yeah, that was one thing I wasn't able to really go over in my case study. We were very fortunate using the data that I was able to show you to really garner the support of our legislature and our governor this year to support them beginning to fund some of our resident slots. So this year we gained 9 additional state-funded GME slots. And so we're very pleased with that, and those are obviously targeted at areas that are shortages in our state. We're also looking at a whole variety of ways to potentially expand that sort of effort and to see if there's partnership, non-public partners in the nonprofit world who might partner to further enhance that. The final is, of course, those residency slots. We use the same strategy of trying to expose them to rural areas in hopes they'll choose one of those areas to practice in, and we know the fact that they've done a residency in New Mexico is the biggest predictor that will actually keep them in New Mexico.
Great, thank you. Dr. Collins, do you have any ideas about Colorado residency slots?
Yeah, I think it's a great question. I do want to point out, and I thought about whether or not to make a big point of this during my talk. Recognize that from a national standpoint, the answer to a diverse healthcare workforce has to be increasing the number of applicants. Once we get to the residency position, we're actually, if you will, we're fighting over the same pool. And that pool is fixed, and it's fixed by who applies and then gets admitted to medical school. So there has to be an intentional local institutional commitment to diversity to say we're gonna do that. So to the degree that New Mexico does a better job of creating an environment that values diversity throughout the system, including residency training, they are likely actually to attract medical school graduates away from Colorado because we don't have that same emphasis. And so figuring out how to create that emphasis on, we know that to diversify the healthcare workforce in Colorado, we have to have people in postgraduate training do their residencies in Colorado, at least from the physician standpoint. I would say the same thing is true of advanced practice nurses and of physician's assistants, that people tend to practice where their last training is done. And so having that value is really important. But I want to make sure that the questioner realizes that we're kind of competing for the same pool of folks. That being said, residency training is kind of the last area of true independence from a lot of things like the General Assembly, unless state legislators or, as Dr. Larson said, philanthropy steps up to the table and funds these slots. The slots are funded through HRSA and through Medicare, and we may see some indications that diversity is important, but it's hard to do that at the federal level, saying that, we want your residents to be diverse, when there's a recognition that the overall supply is fixed. I hope that makes sense. I'm trying to figure out a good way to make that clear.
Yeah, I'd like to just follow up with one kind of caveat. In New Mexico, we're a little bit fortunate in the sense that obviously because we're a majority minority state, increasing the size of the pool is, in some healthcare professions, important in terms of enhancing minority. But in many cases for us, it's really identifying the students that will actually be successful in getting through the educational experience.
Right.
And that's why we've really put a lot more emphasis on trying to identify those students and more effectively do it than to just look at enhancing the pool size.
Yeah, and
that's what we do try to do with the pipeline programs.
Yeah, I don't disagree with that at all. I think that's right on.
Great. I know that we're running a little over on time, but I have one quick question for Dr. Colonge. Specifically, can you give us more data about the Service Corp model in Colorado and how that's working, or where to get more information about that?
So the contact would be Steve.Holloway, Holloway, at state.co.us. Steve is the director of the primary care office, and when I was at the State Health Department, the Colorado State Service Corps was kind of his brainchild, and I think he's the best source for the information. But the idea was to take all of the disparate programs that included the J-1B visa program, which again looks at foreign medical graduates practicing in underserved areas. That program plus loan repayment for physicians, for dentists, and for nurses, put those all together in one project and run it under the overall umbrella of a state health service corps approach. So then it brings in the assessment of medically served population or medically served area. It brings in the elements of the National Health Service Corps in determining needs. It supports the definition of FQHCs for communities that need enhanced reimbursement in order to provide services to low-income patients, and it puts it all under a single program. Steve, as the head of that program, would be the best person to talk about success.
Great, thank you. Again, I would like to thank today's speakers and all of the attendees for your time and participation in this very important conference call and webinar. Again, thank you very much, and if your question was not answered during the live event, someone from NCSL will be in contact with you next week to ensure that your question does get answered. And with that, we will close the webinar. And again, thank you.
Thank you.
This does conclude today's webinar. We thank you for your participation. You may disconnect your lines at this time and have a great day.